Good evening, everyone. How are you all? All right, so welcome to First Aid AMC MCQ 2 weeks free sessions again. Tonight we are going to do a very important topic for you. So it's going to be cardiology. Cardiology is a vital part of your MCQ preparation because you'll get a lot of questions from here. And our sessions for cardiology is divided into three classes for theory session, and then one session we will be doing some question solve. So mainly as a free session, you will get two class, which will be cardiology part 1, which is what we are doing today, and then another class for cardiology 2. Cardiology 3 is our ECG class, which is normally a part of our course student. But apart from ECG, in these free sessions, we are going to cover almost everything that is needed. Okay, so I'm sure you will enjoy cardiology class today and you will learn a lot of things. So as you know that for MCQ, medicine plays a vital role because maximum amount of questions will be from medicine. And out of all the medicine topic, cardiology is the most important one. So let's start and then we can catch up. Okay. If you guys have any questions, feel free to ask me in the chat box. Feel free to ask me about anything related to course at the end of the class. All right. So first of all, let's talk about chest pain. Before that, let's have a look to this video.
The normal heart has two sides, a right side and a left side, and four chambers, the top receiving chambers, or atrium, and the lower chambers, which are thick-walled pumping chambers, called ventricles. Red blood cell will come from either the superior vena cava or the inferior vena cava and enter into the right atrium. The blood then flows across the tricuspid valve to the right ventricle. The right ventricle then squeezes and ejects that blood cell into a vessel called the pulmonary artery. Pulmonary artery splits into two vessels, each going to the lungs. As that red blood cell makes its way through the lung, it returns through the pulmonary veins to the left atrium. That blood is now oxygenated. It's picked up oxygen, then goes across the mitral valve into the left ventricle, which does most of the work in terms of delivery of blood flow to the body. That blood cell is now ejected into the aorta to some organ or muscle or skin in the human body.
Right, I'm sure many of you did not even understand a lot of things. Let's watch it again. This time, watch it carefully.
The normal heart has two sides, a right side and a left side, and four chambers, the top receiving chambers, or atrium, and the lower chambers, which are thick-walled pumping chambers, called ventricles. Red blood cell will come from either the superior vena cava or the inferior vena cava and enter into the right atrium. The blood then flows across the tricuspid valve to the right ventricle. The right ventricle then squeezes and ejects that blood cell into a vessel called the pulmonary artery. Pulmonary artery splits into two vessels, each going to the lungs. As that red blood cell makes its way through the lung, it returns through the pulmonary veins to the left atrium. That blood is now oxygenated. It's picked up oxygen, then goes across the mitral valve into the left ventricle, which does most of the work in terms of delivery of blood flow to the body. That blood cell is now ejected into the aorta to some organ or muscle or skin in the human body.
All right, guys, can you hear now? I just don't know why the sound is gone suddenly. Yeah, okay, sorry for that. It's just that Zoom is doing it. Let's see. Yep. Now, can you hear me and also can you see the screen? Yeah, brilliant. So let's start. So first of all, we were talking about cardiology. For cardiology, the first thing you guys need to know is how your heart works. Let's talk about that, and then we'll come back to some of the important topics that we need to go through. So first of all, when we look at the heart, let's say that this is our heart like this, and we know that heart has 4 chambers. And these are the upper chambers, which are known as atrium. So we have right and left atrium. We have right ventricle, left ventricle. These are the lower chamber. Now, the bloods from upper part of your body, which means from the brain and everything. So upper part of the blood from upper part of the body will be taken by superior vena cava, and blood from your lower extremities, which means from your legs, will come through the inferior vena cava to the right atrium. Now, these bloods that vena cavas are bringing back to your heart, these are deoxygenated blood. So this deoxygenated blood will come from whole body, that means upper part, lower part, into the right atrium. In the right atrium, the blood will go into the right ventricle through the tricuspid valve. So far, all of these are deoxygenated blood, right? Then, if we just change the color for your better understanding, deoxygenated blood will then move into the pulmonary artery. And in here, we have got the pulmonary valve. So now deoxygenated blood from right ventricle is going into the pulmonary artery. From the pulmonary artery, deoxygenated blood will then go to the lungs. Okay? So in the lungs, deoxygenated blood will become oxygenated. How it does this oxygenation? So you know that there is alveoli, which is one of the unit of the respiratory system. So each of the bronchus will become bronchiole, terminal bronchiole, then becomes alveoli, right? And in the alveoli, so you know that you're taking oxygen through your respiratory tract. So oxygen is going into the alveoli. And in here, we have the capillaries. So this deoxygenated blood will be carried to these capillaries, which is carbon dioxide. Now, in this alveolar membrane over here, there will be gaseous exchange. So in here, the oxygen will come to the capillaries, and carbon dioxide will diffuse back to the alveoli, and when you exhale, this carbon dioxide will go out. Right? Such a good physiology of human being. Now, in the lung, this is how it becomes oxygenated. So now from the lung, oxygenated blood will coming into the left atrium through the pulmonary vein. So now this is oxygenated blood, right? Oxygenated blood, and then from left atrium, it goes to the left ventricle by mitral valve or through the mitral valve. And then blood comes to the left ventricle, and then from left ventricle, it goes to the aorta. And in here, we have got the aortic valve. And through the aorta, blood will move to the whole body. Okay? So what happens that there is systole and diastole. The systole is the contraction of the heart, and diastole is the relaxation of the heart. So each time heart get relaxed, the blood will come from the superior vena cava and inferior vena cava into the heart. And then heart will then, in systole, it will contract all the blood through the aortic valve into the aorta. That's how our systole and diastole happens in the heart. Okay? Just to recapitulate, for if someone did not listen to me for the first time, so deoxygenated blood will come from the upper extremity through the superior vena cava into the right atrium. Deoxygenated blood from lower extremity will come through the inferior vena cava into the right atrium. And now in here, all the deoxygenated blood is. Then it goes to the right ventricle. Through the right ventricle, it goes to the pulmonary artery. It goes to the lung. Lung makes it oxygenated. Then oxygenated blood will come to the left atrium through this pulmonary vein. Then it goes to the left ventricle, and then through aortic valve, the left ventricle will push the blood into the aorta and then goes to rest of the body. Does it make sense to everyone? Because this is the most important thing. Throughout the cardiology class, this simple basic will help you a lot to understand a lot of things we're going to talk. Everyone clear? Okay. So if we see here that tonight we are going to discuss about what are the main cardiology chapter that we have. So for cardiology preparation, these are the research that we are going to follow. So the part of your preparation is always based on first you listen to my theory class, and after that you go and read what we have talked in the class. Then you can go to any Q bank if you like, or sometimes there are collections of multiple similar questions from same topic in various groups and all, like recalls. You can solve them. So basically what we say that you read everything that we do in the class, then solve some questions in a Q bank, then come and do a cardiology mock test in our portal. That's how your preparation should be. So first of all, let's talk about what are the theory knowledge you need. So we are going to follow John Murtagh 8th edition. That's for all of these chapters are cardiology chapter. We follow Kaplan step 2 CK. We also follow therapeutic guideline. For chest pain, we will be following therapeutic guideline a lot. RSCGP guideline, for any medicine topic, RSCGP guideline is really, really important. And a lot of questions come from here. And the lecture note will have almost everything that you need for cardiology anyway. Okay? Now let's start with the chest pain. It's already uploaded in your portal. So if any of you can't find out in the portal, it's already there in the theory session. If you go to recent theory session, it is already there. If not, then we will do it later on after the class. First, listen to what we are discussing today. Okay? So, chest pain, very, very important for exam. We are going to follow therapeutic guideline. We are going to follow John Murtagh, chapter 30. So if you have John Moortag 8th edition, please open it, keep it in front of you so that in case we are discussing something, you can also catch up. So if we get a patient who has chest pain, what are the differential diagnoses of that? So first of all, the first and foremost thing that we want to rule out is whether the patient has got heart attack, which is myocardial infarction. We look for angina, pericarditis, mitral valve prolapse. These are the cardiac causes of chest pain. Then vascular, very important, is to rule out aortic dissection. Then we should look for any respiratory related cause like pulmonary embolism, pneumonia, pneumothorax. Remember, all chest pain related to respiratory cause will give you pleuritic chest pain. Pleuritic chest pain is a kind of chest pain which gets worse with deep breath or coughing. So if the question say that the pain gets worse with inspiration or deep breathing or by giving a cough, so that means that they are talking about pleuritic chest pain. And in pleuritic chest pain, these are common causes. Do not forget gastrointestinal cause because many times simple reflux can come as chest pain. Also, we should rule out esophageal tear, peptic ulcer, biliary disease. Musculoskeletal is not uncommon, so we should always rule out costochondritis, fractured rib. Some patients can come to us like their chest muscle is very sore. And if you ask them, then they will say that, yes, just recently I started going to the gym and I've been lifting a lot of heavy things. So that is simple musculoskeletal chest pain. So not every chest pain is dangerous or serious. That's also important to know. But if a patient comes to us with chest pain, we will always take them seriously until we can prove otherwise. Neurological cause, herpes zoster or shingles can also come to us with chest pain. Because herpes zoster or shingles give a burning rash. So that can also present as a chest pain sometimes. So you can see that this is from John Moortag. These are all the causes of chest pain. You can give it a read in your own time later on. Now coming to causes of chest pain. So there are, as you can see already from the differential diagnosis, there are lots of causes of chest pain. So first of all, how aortic dissection chest pain will present to you. So various chest pain has different way of presentation. And you need to know them because otherwise you will not even understand what they're talking about. Like if a patient having myocardial infarction chest pain, let's say that we are talking about acute coronary syndrome. Myocardial infarction chest pain is described as tightness, heaviness, or pressure feeling. So if a patient say that I feel my pain is on the left side of my chest, it's sudden, it's severe, and also it feels like tightness. Someone is sitting on my chest. It's like grabbing, it's heavy, pressure. Those are all features of myocardial infarction or acute coronary syndrome kind of chest pain. So left-sided chest pain, which is sudden, severe, feels like tightness, heaviness, goes or radiates to the neck, jaw, left arm, right arm, or back. Then we will be very concerned about an acute MI. Sometimes chest pain related to acute coronary syndrome can be felt in the epigastric region. So if it is a middle-aged or elderly patient coming to you with a sudden onset epigastric pain, do not forget that this can be a patient who has acute MI. Very important not to forget that. Along with the chest pain, acute coronary syndrome pain will be associated with nausea, vomiting, And they can also have excessive sweating. They can have shortness of breath as well. So those are common associated symptoms in myocardial infarction. Now, how about pericarditis chest pain? Pericarditis chest pain has a different way of presentation. Many times, pericarditis patient will have a recent viral illness, and in response to that recent viral illness, they can come to you with they can also come to you with a sudden chest pain. But the pain will be sharp and stabbing. So if the patient say, yes, I have got a chest pain, many times it is left-sided or retroesternal, and it's called sharp, stabbing, knife-like chest pain. And if you ask the patient, can you pinpoint to an exact area? Sometimes they can say that, yes, this is exactly where the pain is. And very important clue is that this is also pleuritic chest pain. So the pain will get worse with taking deep breath or giving a cough. Pain will be relieved if they lean forward, but it will get worse when they lie down. If you examine the pericarditis patient, you will get pericardial rub, which is a very common clue in the exam. All right, so sudden onset, sharp, stabbing, pleuritic chest pain, which get worse with lying down, better with leaning forward, that's pericarditis. Next is aortic dissection chest pain. Now this is also sharp, but this will be extremely severe pain, 10 by 10. So patient will say, I've got a sudden, severe, sharp chest pain, feels like tearing. And the pain will be retroesternal, that means just center, and it will radiate to the back. Then we think of aortic dissection. So sudden onset, severe, sharp, excruciating pain, feels like tearing, retroesternal, radiating to the back. So these are our main common three causes of severe chest pain. Now, if a chest pain respond to glyceryl trinitrate or nitroglycerin spray, most of the time you would think that it is most likely it is related to ischemic heart disease, or it can be esophageal spasm. Always remember the chest pain that get worse with nitroglycerin could be due to gastroesophageal reflux disease. So if a chest pain gets better with nitroglycerin, most likely it is an ischemic heart disease, or there is a condition called esophageal spasm, where patient gets intermittent chest pain with dysphagia, swallowing difficulty. That also can get better with nitroglycerin. But if a chest pain gets worse with nitroglycerin, we think that it could be reflux. These are small clue in the exam. You can see in here that these are the commonest presentation of various chest pain. Like if it is myocardial infarction, the pain will be severe and usually lasting for more than 20 minutes. In patient who has pericarditis, we know it is sharp pain, get worse with lying down and relieved by sitting up or leaning forward. Dissection, pain is sharp, tearing, radiates to the back. Now come to others. So if it is a costochondritis, so costochondritis is inflammation of the costochondral junction. We will discuss those things later on one by one. Costochondritis is a pain which will also get worse with deep breath. But how to differentiate it from other pleuritic chest pain? Costochondritis is one of the, like you can say, one of the few causes of chest pain where if you press on the chest, it will be tender to touch. So if you press on the chest and patient say, yes, it's sore, that's likely to be costochondritis. So it is tender to palpate. We know reflux will have lots of history, like they will have burning chest pain. It is also central, but they will give a lot of history of burping, belching. They will talk about water brush, which means their mouth get full with saliva. Those kind of things will be there. If it is peptic ulcer, they will have epigastric pain, usually related to some hot, spicy food. So all of these are important, clue to the exam, okay? So we are talking about if there is chest wall tenderness, we think costochondritis. We know about pericarditis now, we know about aortic dissection now, we know reflux now, we know about ulcer. Ulcer is usually epigastric pain related to eating. Can be worse with eating, can be better with eating, but the pain will be related to eating. Okay, now few other physical examination finding related to chest pain. You can give this a read. It's not important for me to discuss. So I will move on to the testing. So far you know various causes of chest pain and how they can present. Okay. So I'm not going into the pulmonary causes of chest pain because we will discuss that in respiratory system. We are mainly focusing on the cardiac causes. Okay. Now, let's say we have got a patient who has acute chest pain. What will be our initial test? What will be our next most appropriate test? Definitely, electrocardiogram or ECG is always going to be our first line test, especially if it looks like a heart-related symptom. Now, does ECG can be confirmatory test for all the chest pain? No. ECG only helps if it is a ST elevated MI. Most of the time, that is the only help you can get. Sometimes, in, in some ischemic heart disease, we can get ST depression, T inversion. Those can be helpful, but main thing in the ECG in an acute chest pain patient, we look for ST elevation. Now, we will come into those, so don't get worried. So our first investigation is always going to be ECG in an acute chest pain. What else? If we are suspecting that no, there is no ST elevation, but without ST elevation, patient can have myocardial infarction. So what else can find out myocardial infarction? Cardiac enzyme. So there are lots of cardiac enzyme we can do, like we have CKMB, but nowadays the most important or most commonly done is the cardiac troponin. And that is the most specific and sensitive test. And then sometimes we can do myoglobin. There are differences between these three tests that we can do in an acute coronary syndrome patient. So the most commonly or the most preferred test is cardiac troponin. Cardiac troponin, now you might think that, well, this patient has got ST elevation MI. The troponin will just be elevated within a day, within 1 hour. So remember, for a cardiac troponin to get elevated, it can take even 4 to 6 hours. That's why just because your first troponin was normal, let's say someone came to you with a sudden onset chest pain, which started 2 hours ago, and chest pain is still there. So for 2 hours, left-sided chest pain, the pain is radiating to the arm and everything. So you think that this is an acute coronary syndrome patient. You did a ECG, normal. You did a cardiac troponin, it also normal. Will you stop and just send the patient back home? What do you think? No, you can't. So because you need to keep on repeating the troponin. So you need to repeat, so yes, observe the patient, and then you do repeat ECG every 1 or 2 hours, and you repeat the troponin. Okay, at least for 4 to 6 hours since the onset of chest pain, you need to keep on repeating the troponin. Okay? So serial troponin, yes, Dr. Saima, very good. So serial troponin, serial ECG is the way to go if you're suspecting an acute coronary syndrome. Now, once troponin gets elevated, it can stay elevated for sometimes even 10 to 14 days. How about others? CKMB also takes 4 to 6 hours, but it just stays elevated for 1 to 2 days. Myoglobin, very rarely we will ever do. Okay? Now the question from here is that, let's say we have got a patient who has elevated troponin, and you have treated the patient as myocardial infarction. Okay? Now, if you see that no, like even after treating the MI patient, just after 5 days, patient again started to get the chest pain. We are worried at that time that whether this patient might have got a reinfarction. So if we want to check reinfarction, what will be the best test? CKMB or troponin? Yes, because if you are looking for reinfarction, troponin is not going to be helpful because it's going to be elevated for 10 to 14 days anyway. So that's why it is best that if you're suspecting it is a case of reinfarction, then you go for CKMB. Okay? The most sensitive, most specific cardiac marker is troponin, Dr. Nazam. So far we understand that we will definitely start with the ECG, and then we have got cardiac enzymes. As part of cardiac enzyme, if we have options between CKMB, troponin, myoglobin, we will always do the cardiac troponin as our preferred one. Which one? Troponin I, troponin T? Troponin I, yes. See that like questions can be really difficult if we don't know important thing. Why not troponin T? Because troponin T sometimes can be elevated in renal diseases. So if someone has got renal problem, the troponin T can be elevated. So that's why between troponin I and T, troponin I is much more specific. Good. Moving on. So sometimes patients can have pulmonary causes of chest pain. So when we are thinking pulmonary cause of chest pain, then chest X-ray is going to be one of the useful tests, and lots of others are there, which we will go on when we discuss those specific topics. Okay, so now we know what are the causes of cardiac chest pain, what are the investigations we can do, and lots of other specific investigations are there, which we will come very shortly. Coming to what are the risk factor of cardiovascular disease? Sometimes question will ask you this kind of like silly questions or one line question that they will say that you've got a 50-year-old patient. What is the single most important risk factor for cardiovascular disease for this patient? So always remember that the most important risk factor or single most important risk factor for cardiac disease is elevated LDL cholesterol. Okay, this carries the significant risk or the highest risk of having cardiovascular issues. So we have got one which is the highest risk of cardiovascular problem or most important risk factor. Other question is, what is the worst risk factor for a patient who has coronary artery disease? The worst risk factor is diabetes, because some of these patients will have silent MI. They will not even get the chest pain. And they have a very poor prognosis, because if they need any operation, it can take longer time to heal. They have more chance of getting infection. So the worst risk factor in a coronary artery disease patient is always diabetes. And if the question asks what is the most common risk, that is hypertension. So understand the question. The single most important, or the single most important, or the highest risk for cardiovascular disease is elevated LDL cholesterol. Worst risk factor is diabetes, and the most common risk factor is hypertension. So this is one of the questions, that which of the following is most dangerous to a patient in terms of risk for coronary artery disease. So we know from this elevated triglyceride, elevated total cholesterol, decreased HDL, elevated LDL, or obesity. So elevated LDL is always going to be the most dangerous. There is a condition called tachycardiomyopathy. Now, this is very rarely it will be ever asked, but you will be amazed to know that there are lots of patients that we get this tachycardiomyopathy nowadays. So you should know what is tachycardiomyopathy, because this is a cause of chest pain, but there is no coronary artery blockage in this patient. So tachycardiomyopathy is an acute myocardial damage often occurring in postmenopausal women immediately following an overwhelming, emotionally stressful event like divorce, financial issues, earthquake, lightning strike, hypoglycemia. What it does, that it causes ballooning of the left ventricle, and left ventricle stop moving. Okay, so this is what we call left ventricular dyskinesia. That means normally your left ventricle is the strongest part of the heart, and it needs to be strong because it needs to push the blood to aorta. So in patient with tachycardiomyopathy, left ventricle suddenly stop moving, and if it doesn't move, your heart doesn't get blood supply, nothing gets blood supply. So if heart doesn't get blood supply, it will felt as a chest pain. Okay, so you can see this question: a postmenopausal woman develops chest pain immediately on hearing the news of her son's death in a war. She develops acute chest pain, shortness of breath, and also ST elevation in lead V2 to V4 on ECG. And she got elevated troponin. So this is why it becomes very confusing. You will feel, or you will think that this is an acute ST elevated MI, and you will treat it accordingly. Then you went for, like, let's say you went for coronary angiogram, but angiogram will say there is nothing wrong. There is no block. That is the time you will say that no. So if without block, if a patient gets similar feature like a ST elevated MI, that is tachycardia. Then if you do an echocardiogram of the heart, you will see that the left ventricle has got a ballooning and it's having the dyskinesia or no movement. That confirms the diagnosis. Treatment, ideally we manage them with beta blocker or ACE inhibitor. Because there is no blockage, there is no need to put a stent in this patient. Okay? And why it happens? Because in response to certain overwhelming news or events, they have this massive catecholamine discharge. And that means their sympathetic nervous system gets super excited. And because of that, they get vasospasm. That means their coronary artery also get, if this is the normal coronary artery, their coronary artery becomes like this. Okay? So vasospasm is the main problem. And in response to that, the left ventricle stop moving, it starts to become ballooning. So that causes this tachycardiomyopathy. So the main thing to remember that if you have got a postmenopausal woman with a sudden onset chest pain, ST elevation, cardiac troponin elevated, but you took the patient for angiogram, there is nothing wrong. That is the time you only would think of Takotsubo. And the confirmation can be done by an echocardiogram. All right. So the next question is correcting which of the following risk factor for coronary artery disease will result in most immediate benefit for the patient. These questions come in exam. So remember that if a patient do a smoking cessation, that will be the greatest improvement in patient's outcome. So all of these risk factors come in exam. So please remember them. Now, we are moving into more important topics, myocardial ischemia. So we know that myocardial ischemia, the site of the pain is this. So you see it is left-sided. It can radiate to our left arm. It can even felt in the epigastric region. It can felt in the neck or jaw. It can even felt in the back. Pain is referred into the left arm more commonly than the right arm. But the best predictor for acute myocardial infarction is pain in the both arms. So this is important. So if question asks you that what is the best predictor for acute myocardial infarction in terms of pain? In terms of pain, the best predictor is when a patient gets bilateral or both arm radiating pain. Okay? So we know that myocardial ischemia, the quality or characteristic of the pain will be pressured, heaviness, tightness. Along with that, this patient also will have shortness of breath, dizziness, nausea, vomiting, excessive sweating. This is a very important clue. These are all from John Mottag. If a retrosternal pain, almost identical with myocardial ischemia, is precipitated not by exertion, but by bending, lifting, straining, or lying down, consider esophageal reflux. So this is an important thing, like patient coming to you with a central retrosternal chest pain. And they're saying that the pain doesn't get worse with exertion, but it gets worse when they lie down or they bend over. That's likely to be reflux-related pain. So when we talk about myocardial ischemia, a lot of the things come in there. So we need to know what is angina and what is actual myocardial infarction. So if we look over here, ischemic heart disease has been divided into multiple different things. So first, patient might be totally asymptomatic, patient might be symptomatic, and symptomatic means chest pain. If a patient has symptoms, then we divide them as either they have stable angina or they have acute coronary syndrome. So who are having a stable angina and who are under acute coronary syndrome or ACS? Stable angina, if you look over here, a normal patient's their blood vessels should be completely open, right? There should not be any block. But you can see a bit of atherosclerotic plaque over here. In a patient who has a stable angina, they will have a little bit of atherosclerotic plaque. That means fatty deposition. So without exertion, they still have a lot of place in here and blood can easily flow in and out. But when they do exertion, in exertion, their oxygen and blood requirement increases. At that time, because it's a bit narrowed, it becomes hard for the blood to reach everywhere in time. Then they get the chest pain. So if a chest pain gets worse with exertion only, and it's last let's say maximum 10 minutes, and it gets better with taking rest. That is a stable angina. If we come back, the stable angina, the pain of angina lasts very few minutes, average 3 to 5 minutes, never more than 15 minutes. It is relieved by rest and also nitroglycerin. Okay, so chest pain which comes with exertion lasts 5 to 10 minutes, get better with rest. That's a stable angina. What about acute coronary syndrome? Acute coronary syndrome has three things in there. We have unstable angina, we have non-ST elevated MI, and then ST elevated MI. Difference between these two and this one is that unstable angina and non-ST elevated MI, they will have a little bit space left. They will not be completely blocked. Okay? That's why they call subendocardial infarction, especially this one. So this unstable angina, they have a little bit more space left. And then they become more and more blocked. That becomes non-ST elevated MI. And when it becomes completely blocked, it becomes ST elevated MI. Okay? So this is the important thing to know, that ST elevated MI means that there is no way for the blood to reach distal to this block. Okay? That means that is the worst thing to get. So unstable angina, the pain will be similar like ischemic heart disease pain. So pain on the left side and pain radiating to all of those areas. The important thing is that the pain will last more than 10 minutes. So it is a pain which lasts at least 15 to 20 minutes according to John Murtagh. So it will not get better with rest. Okay? And sometimes even at rest, patient can have pain. So unstable angina is patient who is having similar chest pain, and the pain is not getting better with rest. Pain is not getting better with nitroglycerin, and it lasting more than 15 minutes. Okay? Now you can say that the same thing also happened with myocardial infarction. Remember, myocardial infarction, the pain will be much worse. So it will be sudden, severe chest pain, and it will not resolve. It will be heavy, crushing, and it can be intense. Sometimes just by looking at the symptoms, it is very difficult to differentiate between these two. So we can't most of the time differentiate based on the symptoms only. A lot of other things we need. So understand that it is easier to differentiate between a stable angina versus acute coronary syndrome, because a stable angina will get better with rest. Any chest pain which does not get better with rest, lasts more than 15 minutes, it becomes a part of acute coronary syndrome. And then we need to find out what it is. Is it unstable? Is it non-ST elevated or ST elevated? That comes with investigations. You already know about the characteristic of the chest pain, so I'm not going in there anymore. Now, we have found a patient who has acute coronary syndrome. It fulfills the criteria. What's next? We do an ECG. The ECG, if it shows ST elevation, then we can say it is ST elevated MI, straight away. But let's say no ST elevation. Then, if there is no ST elevation, it is either unstable angina or it is non-ST elevated MI. How to differentiate? The only way you can differentiate between these two is to do a cardiac troponin. If cardiac troponin negative, it becomes unstable angina. If cardiac troponin positive, it is a non-ST elevated MI. Make sense, everyone? So this is what we have kept as a difference between these two. So unstable angina and non-ST elevated MI, the main difference is the troponin. The type of pain will be same, but the difference is that unstable angina patient will not have any necrosis of the heart muscle. And non-ST elevated MI patient will start to have that necrosis. Because of necrosis, the troponin will be elevated in non-ST elevated MI. Okay. All right. So we know about stable angina. We know now about unstable angina. Unstable angina has different type as well. Nocturnal angina, that means that there is chest pain, which occurs at night when they lie down. Sometimes chest pain, which occurs when lying flat and relieved by sitting up. Variant angina or fringe metal angina, we will discuss them later on. So sometimes if a patient say that I get pain in the night time when I lie down, that can be also an indication of unstable angina. Okay, so don't just think that no, it just happens during night, you must be resting, you should not get a heart pain. It's not the case. Okay, unstable angina, the pain can happen even when they're at rest. Yes, left untreated, unstable angina will become a non-ST elevated MI. Now we are moving on to some of the investigations that we do for a stable angina patient. So first thing is always the same. You do a baseline resting ECG. Okay, so if you do a resting ECG, most of the time, stable angina patient will not have any problem in the ECG. Look at the ECG. Normal thing is this is the P wave, then followed by QRS, and then T wave. So if you see that this is called isoelectric line. So all of them should be in the same line. In a patient who has a stable angina, when they are at rest, they will be having just a normal ECG. But you are suspicious that, well, this patient might have something wrong. This patient might have angina. So what you do? You send the patient for exercise ECG or a stress test. So in the stress test, patient need to run on a treadmill. And when they run on a treadmill, you are putting the patient on exertion. And then you look for any ECG changes. What kind of ECG changes you are looking for? You're looking for whether there is any ST depression. So now you can see this is the isoelectric line, but ST has gone down. What you can see here, so this is ST depression. If during exercise test or stress test, there is ST depression, or if the T wave becomes like this in multiple leads, not just single lead, multiple contiguous lead, then you would be concerned that, well, this patient most likely has got ischemic heart disease. Okay, so you did an ECG, nothing came up, you send the patient for a stress test. Remember, a normal stress test does not always rule out coronary artery disease. It's just 75% cases, it will be positive. So if you're in doubt, you might need to do further investigation. What else we can do? Now, this is where we make it a little bit complicated, but it is important for you to understand this test. So first thing I say that we can send the patient for a stress test. For sending a patient to a stress test, we need two things. One, that there is no baseline ECG abnormality. That means ECG is normal and the patient is able to exercise. If you send a 80-year-old patient who has lots of arthritis to a treadmill exercise, that patient is going to hate you. or patient will not be able to do it. So you need to first find out whether that patient can exercise on a treadmill, and also whether the ECG is normal. So if ECG is completely normal and patient can exercise, then only you can send the patient for a stress test. Okay, so the first thing is that if patient's ECG is having some baseline abnormality, what are the baseline abnormality they can have? They can have left bundle branch block. You can see left ventricular hypertrophy. Patient might be on a pacemaker. So if there is any abnormality on that ECG, the resting ECG, then you can't send the patient for the exercise test anymore. So what will you do? The best way at that time is that you send the patient for either a nuclear scan or you do a stress echocardiogram. Now remember, for this, you think that patient can exercise. So in nuclear scan, patient will run on a treadmill, but patient will also have a dye. So they will have a dye in their arm or in their vein, and the dye will go to the heart muscle, and it will find out if some part of the heart muscle is not getting enough blood supply. Okay, so either you do the nuclear isotope scan, which is the thallium scan, or you can say it's a dye test, or you can, patient will run on a treadmill and you do an echocardiogram, which is called a stress echocardiogram. So if we come here, we think chest pain is cardiac origin. We look at the resting ECG. Is the resting ECG having any abnormalities? No. If resting ECG does not have any abnormalities, the next thing we want to know, is the patient able to exercise? Yes. Then we send the patient for a stress test, which is the first one that we talked about. But let's say the resting ECG has some abnormality. In that case, we can't do the stress test anymore. So we need to do the stress echo or a stress nuclear test. So a stress echo is patient run on a treadmill, and then we just do an echocardiogram. And a stress nuclear test, patient run on a treadmill, and we put a dye on it. Okay? What if patient is not able to exercise? Then you can't do the stress. That means you can't put the patient on a treadmill. So to make the heart under exertion, you can give some medication which will feel like the patient is working. So that's called chemical stress test. So either we do dipyridamole thallium test, or we do dobutamine echocardiogram. So these are chemical or drugs which will put the heart in the same way a treadmill will do. Okay? Let's make it more simple. So we have got a patient who we suspect patient has ischemic heart disease. The next thing is we do a resting ECG. The resting ECG, we find out, is there any baseline abnormality there? No. Is patient able to exercise? Yes. So no baseline abnormality, patient able to exercise. The easiest way is to do an exercise stress test, which means patient run on a treadmill and we only look at the ECG. The next thing could be that patient unable to do exercise. So they can't do exercise. So we need to put the heart under stress. So we give chemical stress test. And for chemical stress test, we have these two, dipyridamole thallium, which is a nuclear test, and dobutamine echocardiogram. Other could be that patient has some baseline ECG abnormality, but they can exercise. Then we do a stress thallium scan or a stress echocardiogram. That means in here, patient will be running on a treadmill because they can exercise, but we will be doing a tie test or a echocardiogram. Okay? Clear, everyone? Does it make sense? I know this is the hardest topic out of everything that we are going to discuss tonight. But try to understand that, like, what to do if a patient can't exercise. If patient can't exercise, then we do a chemical stress test. If patient can exercise, but the problem is that they have a baseline ECG abnormality, then we do the stress echo or a stress nuclear test. Okay, Alex, so if baseline ECG is there, patient baseline ECG having problem, so why in normal ECG we need to do a stress test or nuclear test? Because you are worried, because you are suspicious of a cardiac pain. Not all cardiac pain will be you will not get ECG abnormality for all the ischemic heart disease, right, Dr. Shukon? Because many ischemic heart disease, their baseline ECG is normal, but they are getting the pain. So you need to find out whether they have any problem when the heart is under stress. You can do it, but it is only time we do this chemical test when patient cannot exercise. You can do it. It's not like we can't. We can. But this can be quite risky as well sometimes because we are giving chemical for the heart to work. So if a patient is able to exercise, then why we would give chemical to that patient? This is more invasive. That's why we don't do it. But we can if we want. No, if a patient has ECG abnormality already and patient cannot exercise, then that usually we can't do much about this. Then we go for a coronary angiogram directly. Okay, so make it simple. Don't make it complicated as like more than what it is. I know you guys want to make it as complicated as you want, but the simple thing is very simple and keep it simple for exam. So, and the exam will be simple as we normally would get in real life situation. So if we have got a patient who has suspected ischemic heart disease, we did a resting ECG, nothing coming up, we're still worried about the patient, then we look for two things. What is the ECG looks like, the baseline, and is this patient able to do exercise? If patient's baseline ECG is abnormal, then we directly go for a stress echo, which is exercise echo or nuclear test or thallium test, same thing. Is the patient not able to do exercise? Then we go for chemical stress test. If you make it simple, it will become simple in your mind. There is no problem with ECG. Patient also can exercise. Then we go for exercise stress test. Okay? All right. Now, let's say that there are some patients where you will get this positive finding. So let's say someone's exercise stress test came back positive, or chemical stress came back positive, or any of this came back positive. Any of these positive means that they have ischemic heart disease, which means they have some kind of blockage in their heart. To find out how much blockage is there or where exactly is the block, then we do a coronary angiogram. Coronary angiogram involves they insert a catheter through the wrist or groin artery, and then they guide the catheter into the coronary artery, and then they put a dye. The dye will go to all the branches of coronary artery, and it can say, or it can find out where exactly is the block, how much blockage is there. So you can see that this area, the dye is not getting similar like this one. So these are the blockages. Okay. So coronary angiogram is the main, or you can say it is the definitive test to be sure where exactly is the block and how much blockage is there and how many vessels patient has blocked. So based on the coronary angiogram, if it is one or two vessel has got more than 70% block, then the cardiologist will put a coronary stent. So they put a stent to keep it open. If it is three vessels, so three vessel has got more than 70% block, then coronary artery bypass graft. So then we go for CABG. Okay, makes sense, guys? That from where we do all of these things. So these are the indications of coronary angiogram. The most important thing is that if there is a strongly positive exercise test. So there are lots of other indications, but I want you to remember only one, that if you do this stress test, so a stress test can be any of them. These are all a stress test. If you do a stress test and it come back positive, then you need to send the patient for an angiogram to define where exactly is the block, how much blockage is there, and what kind of procedure this patient will need. In your country, you might not do this because you just do it when patient comes to you with acute MI. But in Australia, we want to prevent acute MI. We don't want the patient to go into MI if we can. So some of the patient will get a stent even with angina, because we start all this investigation when patient starts to have angina. So even with stable angina, patient will get all of these tests one by one. So before it becomes acute MI, the patient might even have a stent in there, and it can prevent a significant major problem in their life. Okay, so that is what we do in Australia. So this is all about patient who had a stable angina so far, not acute coronary syndrome. For acute coronary syndrome, there is different management. So prevention, so any patient who has this kind of ischemic heart disease, the prevention is lifestyle. So no smoking, weight reduction, exercise, these are always there. Medical treatment. So before they get all these tests, you need to put them on some medication to help them with this pain. The most common medication that we use in a stable angina is nitrate. So it can be given as a spray, can be given as sublingual tablet, or can be given as isosorbide dinitrate. So that means nitrate is the main medication during acute pain. If a patient cannot tolerate nitrate, then we can give them nifedipine. So this is mainly for patient who has stable angina. During the pain, they will just take that nitroglycerin. Along with that, for patient who gets a little bit more pain, that means even with moderate exertion, they just walked 100 meters and they're getting the chest pain. With moderate exertion, they're getting pain. Then along with the nitrate, you're going to add aspirin. You are going to add a beta blocker. Okay, so these will be added with nitrate. So aspirin, beta blocker, nitrate is important. Sometimes, if it is a persistent angina, that means the pain is just ongoing, then definitely we need to add amlodipine, nifedipine as well. Now, you don't need to know that much detail. I want you to know that in a patient who has got a stable angina and they are getting chest pain, your main treatment is nitrate. If nitrate doesn't work, or patient getting moderate exertional angina, even with a little bit of exertion, they are getting the pain, you're going to add aspirin and beta blocker on the top of nitrate. But nitrate is the main treatment, and that's what will come. We talked about coronary angiogram, that when we do the angiogram, we talked about angiogram will decide whether the patient need a stent or a bypass. There is another thing called Holter monitoring. Many of you choose Holter monitor whenever you see it in the option. But what is Holter monitor? Remember, Holter monitor has nothing to do with chest pain patient. So it is nothing but a ambulatory ECG monitor. So you put a device on the patient and patient will just keep it on for 24 hours, 48, or even sometimes a week. What Holter monitor will do, they do this like regular interval ECG and they keep a record of it. And after 24 hours, they give it back to you, and a cardiologist will interpret that what happened over the 24 hour. Was there any arrhythmia that normally when we are doing the ECG, we can't find out? Like patients saying that I'm getting palpitations a lot, but you did an ECG in your clinic, there is nothing wrong. Will you stop there? No, because patient might not have the palpitation at that time. So then you put the patient on this 24-hour Holter monitor, and then sometimes the Holter monitor can be able to pick up. Okay? Remember, it is not a test to detect ischemia. It is for rhythm evaluation. So someone who has palpitation, for them we would do it. Okay. Now we are going to myocardial infarction. You guys are ready? You guys are not scared? You are still with me? You're not feeling overwhelmed? All right. Very important, acute myocardial infarction comes in a lot of ways, and exam loves this question. So you can understand that in an acute myocardial infarction, especially ST elevated MI, when a patient starts to get the chest pain, the first ECG change, you can see that their ST has got slightly depressed, but the minutes after the pain, you can see the ST has got over here. So first ST elevation will look like this. You can see how it's changing. There is T inversion and all. So that's a gradual progression of the ECG in a ST elevated MI. Not important for you, just for you to say. Sometimes questions say that what will be the immediate finding in the ECG in a ST elevated MI? Immediately you will get these two features, hyperacute tall T wave. You can see the tall T wave here. And then you get the ST elevation. All right. And then after that, you can get a lot of things, Q waves, you can get T wave inversion, but the hyperaccurate T wave is the first thing, and then you get ST elevation. So the most important thing to remember is how to manage a patient who comes to you with an acute onset chest pain, and then you did an ECG, you found ST elevated MI. So in a ST elevated MI patient, the first thing that we do is we give aspirin. That is the most important thing we would do to any patient. So this is according to therapeutic guideline. So we follow the therapeutic guideline for this kind of important topic in exam. You don't need to to learn everything from therapeutic guideline, your main guideline will be RSCGP and John Murtagh. But important, where John Murtagh failed to explain clearly, we go to therapeutic guideline. So the first and foremost management for a patient who has ST elevated MI is aspirin. That is the first thing because it has benefit of mortality. It can reduce mortality in a MI patient. After aspirin, you can see that the next step therapeutic guideline mentioned is about reperfusion therapy. So you need to plan that what this patient will need to have. Okay, so first we give aspirin. The second thing is reperfusion. Reperfusion means you need to open up the blocked artery. How you are going to do it depends on when patient presented after the chest pain. So reperfusion is recommended if patient presents within 12 hours of onset of the chest pain. So if a patient comes within 12 hours of chest pain, then you can choose a reperfusion treatment. So reperfusion is nothing but there was a blocked artery like this, and you want to open it up. So there are two options. We have percutaneous coronary intervention. We have thrombolytic therapy. Both of them can be tried if patient comes within 12 hours. Remember, because you are always confused about this topic. So in reperfusion, if a patient comes within 12 hours, then we can choose PCI, which is the coronary intervention, or thrombolytic treatment. So percutaneous coronary intervention is nothing but what we discussed in the angiogram. So percutaneous coronary intervention is they put a catheter through the radial artery or femoral artery, and then it goes to the heart, the coronary artery. They put a dye, they find out where exactly is the block, and then either they put a balloon there to open it up, or they put a stent to keep it stable. That's percutaneous coronary intervention. Basically, most of these patients will end up having a stent. Okay. Now, some of these patients might need a bypass surgery also if it is like all blockage everywhere. Now, when we go for thrombolytics are medication like alteplase, retiplase. We no longer give a streptokinase, but yeah, those are thrombolytics. Thrombolytics is an alternative to PCI. PCI is always the best if we can. Thrombolytics is an alternative. Now, remember one thing, is PCI available within 120 minutes of first medical contact? This is the important thing where candidates get confused from John Murtagh. So the idea, John Murtagh said 90 minutes, therapeutic guidelines say 120 minutes, and we will follow therapeutic guideline. So the first medical contact means that when patient first came into your hospital, from that time, are you able to send the patient for a PCI within 120 minutes? If you can, so within 2 hours, if the patient can get a PCI, then the PCI will be the preferred choice. If you can't, let's say it is a rural hospital, and rural hospital doesn't have PCI, and the tertiary hospital is more than 2 hours away. So in that case, you would not wait for the transfer. You will just go for the alternative, which is thrombolytic. So thrombolytic is usually done where PCI is not available, and to transfer the patient to a nearest center where PCI is available is more than 2 hours, then you don't wait because you need to do PCI within 2 hours of the medical contact. In that case, you choose the second alternative, which is thrombolytic treatment. Before trying thrombolytic, you need to make sure patient doesn't have any contraindication to thrombolytic. So if no contraindication, you give thrombolytic. This is making sense till now? There are a lot of other things, but are you understanding up to now? Because this is the most important part. Now, first contact, now the ambulance time will not be counted because it can take considerable amount of time based on from where the patient is coming. But the first time patient goes into the hospital from there. No, it is not 120 minutes from the onset of chest pain. That is where you guys are confused. Remember, first I said, if a patient comes within 12 hours of onset of symptom, you have option of reperfusion. Okay? PCI is 120 minutes from medical contact, which means let's say patient came into the hospital and within 2 hours, if you are able to arrange PCI for the patient, then you go for PCI. If you're not able to, then you go for thrombolytics. Okay, now I understand a lot of other questions about clopidogrel, about lots of things. Let's discuss that. So remember, for every one of these people, will get few other medication as well. So they will get a dual antiplatelet therapy. So doesn't matter whether they are going for thrombolytics, whether they are going for PCI, along with aspirin, they will also get another anticoagulant. Sorry, another antiplatelet. So antiplatelet will be either ticagrelor, prasugrel, or most commonly clopidogrel. So any of these antiplatelet will be added. Not only that, this patient also get a third anticoagulant, which is the, the low molecular weight heparin, so enoxaparin, dalteparin, those things. So all of these patients will get aspirin, will get clopidogrel, and they will also get an anticoagulant, which will be most of the time like any of the heparin. And it's same for thrombolytic patient. They get a dual antiplatelet, so aspirin, clopidogrel, and they also get a parenteral anticoagulant. And parenteral anticoagulant is the low molecular weight heparin. If you look over here, I don't have that slide in here, but yeah. So just remember that patient who has this ST elevated AMI, it's not only just aspirin, they get all these other things. So they get clopidogrel, antiplatelet, and they will get a anticoagulant, which will be most of the time the heparin. Okay. Now let's say you did thrombolytic therapy. Was it successful? Yes. In that case, you would, if it is successful, still the patient might need a PCI. So you will arrange transfer to a center where PCI is available within 24 hours because that patient will still need a angiogram. If it was not successful, then patient needs to be immediately transferred to a center where PCI is available. So thrombolytic is just to settle the patient, but eventually this patient will need a PCI. Now, coming to, so we talked about the dual antiplatelet therapy, which is aspirin plus any of them, which is fine. Coming to what else? Every AMI patient, along with aspirin 300 milligram, they get monotherapy. So Mona A is the aspirin, which is what's the most important. M for morphine. O for oxygen. N for nitroglycerin. So morphine, nowadays even fentanyl is preferred as an IV. So look at here. So first you have given aspirin. The next thing is you arrange for PCI. Always remember that is your next step before you try anything else. For ongoing chest pain, in a hemodynamically stable patient, your next step will be glycerol trinitrate, a spray or a sublingual tablet. And you can give them 3 times every 5 minutes. Now, what does it mean, hemodynamically stable? Why we can't give nitrate in an unstable patient? Nitrate can drop the blood pressure significantly. So if a patient's blood pressure is less than 90/60, you can't give them nitrate. We can't give nitrate to a patient who is taking Viagra or sildenafil within the last 24 hours. So very important to look for this. If hypotension, if a patient is on sildenafil or Viagra, we can't give them nitrate. Even after giving the nitrate, still persistent chest pain, then you choose either a fentanyl intravenous or morphine intravenous. What about oxygen? See this one, give oxygen only if a patient is hypoxic. So if oxygen saturation is less than 92%, that is the only time we would need to provide oxygen to this patient. Not every MI patient will need an oxygen. Make sense, guys? So the questions that comes in exam is like this. Have a look on this question, then you will understand why I'm focusing on this a little bit more. 70-year-old woman comes to the ED with a crushing chest pain for the last 1 hour. ECG shows ST segment elevation in V2, V4. What is the most appropriate next step in management? Now, you don't get that much option in the exam, but what will you do next? And Dr. Apurbo, ideally aspirin, clopidogrel, everything will be given together. But in exam, that is a different thing. For exam, let's have a look how we are discussing the question. You will understand. Yes, the first thing is we give aspirin, right? Next, 70-year-old women, same patient, crushing chest pain, ECG shows ST segment elevation. You have already given aspirin. What is the most appropriate next step? This is what question will be. CK, oxygen, see that everything is here. Nitroglycerin, morphine, thrombolytic, statin, angioplasty, troponin. What will you do next? This is where you will get confused in your exam. Do you want to give morphine? Do you want to give nitrate? Do you want to give thrombolytics? What's your best next step? So this is one of the things where after aspirin, you choose PCI straight away. That's your exam. Now, this is why I have taken that much time. Still, I can see many of you are choosing a lot of other options. Okay, so have a look on this guideline. This is the step-by-step approach that we are supposed to follow. You give aspirin, you plan perfusion, which means your next step will be always reperfusion or angioplasty. And then while you are planning it, while the catheter lab is getting prepared, you do all the others. You give pain relief, you give nitrate, all of the others. But when you in the exam, this is what you are getting assessed. That do you know that what is the next best step after aspirin? Okay. So remember one thing that even this is, if you look on the answer here, angioplasty is associated with the greatest mortality benefit of all the steps listed in this question. All of the answers are partially correct in that all of them should be done for the patient. Like morphine, oxygen, nitrate should be given, but they do not clearly lower mortality. Okay? In In a ST elevated MI, the first and foremost thing is we choose, now this is for your exam, we choose the most important thing as part of mortality benefit. Okay? And yes, so oxygen only if the saturation is less than 92. And that is the reason why I have shown you all of this. You can understand from this therapeutic guideline that this is the step that you are supposed to follow. So you can even see that they started aspirin first. Then if there is ongoing chest pain, they did not talk about morphine, fentanyl. They said, then you try nitrate. Still not working? For persistent chest pain, then we go for morphine. And that will be a step of your chest pain. Okay? So keep it in your mind forever for MCQ exam. It's aspirin first. For ST elevated MI, the next step will be PCI, angioplasty, angiogram, whatever is there. And then after that, you do everything else. Okay? Please do not choose anything else. And I can assure you those will be wrong in your exam if you do that. And that's up to you. I've done my part. So we talked about this 120-minute delay. If you go to John Murtagh, you will see that John Murtagh has said that a time delay of 90 minutes from the first medical encounter to PCI is maximum. But according to ETG, they said 120 minutes, and that's what we would follow in real life. Okay? So what are the contraindication of thrombolytics? So we are talking about if PCI is not possible, then our next option is thrombolytics. You need to rule out any contraindication. If someone has active bleeding disorder, if they had a closed head injury in the last 3 months, if you suspect aortic dissection, any history of bleeding in the brain, anytime, ischemic stroke in the last 3 months, any of this is there, you can't do thrombolytics. So your question would be what to do if we can't give thrombolytics? Then you don't have any choice. You need to transfer the patient to a tertiary center where PCI is available. Okay, that will not be the best option, but again, you can't give thrombolytics to that patient, so you transfer whatever time it takes. What about late presentation? So you could ask me that what if patient comes after 12 hours? What we will do? So reperfusion therapy with either PCI or thrombolytics is not routinely recommended in patients who are asymptomatic and hemodynamically stable who present after 12 hours. Now, will they not get anything? They will. So it means that it is not urgent anymore, that you have to immediately take the patient for PCI. You can wait for 24 hours even to do the PCI for that patient. Okay, so that patient will need a angiogram, but it's not that immediate anymore after 12 hours because we think that after 12 hours, the damage has been done. And given they are not symptomatic, they are stable, it means that it's okay to wait. Now, many patients who is on aspirin clopidogrel, like you are starting the patient with aspirin clopidogrel, if a patient is put on a stent, they will need to be on this dual antiplatelet therapy for 12 months. Because if you don't put the patient on dual antiplatelet, sometimes a stent can have thrombosis. And there are questions which comes for patient who is on aspirin clopidogrel and had a stent and need an elective operation. Remember one thing, that if a patient has been put on a stent and they need an elective operation like hernia operation, maybe a varicose vein operation, you need to delay that operation for at least 12 months after a stent. Minimum 6 months, but for something which is elective like hernia operation, you can wait for 12 months after a stent. Because you can't actually, if you do the operation while they are on antiplatelet, they will bleed, unnecessarily bleed. And waiting for 12 months is not going to change the course of of that elective operation. Okay, so you can wait. But if a patient needs an urgent operation, like someone who has had a maybe neck of the femur fracture, you can't wait for 12 months. In that case, you go on with the surgery and you just stop the clopidogrel sometimes just during the operation, and then you continue the operation with platelets standby. If patient starts to bleed, you can give them platelet. So remember that if a patient is on aspirin clopidogrel and they had a stent in the last, they had a stent and the stent is more than 12 months, then you can do any operation. You can even stop the clopidogrel and get the operation done. But if it is less than 12 months, for elective operation, you just delay the operation for 12 months. But if it is emergency operation, then there is nothing you can do. Patient will be on the antiplatelet, but you just keep platelet standby. So you do the operation with platelet standby. If patient starts bleeding heavily, you give platelet you just go for IV platelet. Okay? Make sense? So once a patient has got ST elevated MI, their long-term medication will continue like this. So they will be on aspirin clopidogrel for 12 months. After 12 months, we will stop their clopidogrel and they will only be on aspirin. Then beta blocker, so any of these atenolol, metoprolol will be continued. Then also we start the patient with ACE inhibitor. And if the patient has high cholesterol, which they will be, we put them on a statin. These are the after discharge medication. So once a patient has all the treatment done, or even during like let's say you put the patient on a stent, patient came back after a stent, then you just put the patient on all this medication. And they just continue this. Aspirin clopidogrel for 12 months, beta blocker, statin, and a ACE inhibitor. Now, what about a patient who has got non-ST elevated MI? Non-ST elevated MI means that it is not full infarction. That means it's not completely blocked. For that patient, there is no role of reperfusion. That means you don't need to do anything like take the patient immediately at the moment, unless patient has very significant high risk. So remember one thing, reperfusion or immediate reperfusion is not needed, like percutaneous coronary intervention or thrombolytics is not needed for a non-ST elevated MI. They will need coronary angiogram, but it can take 24 hours, even few days. That's fine. Because only time a reperfusion is needed when it is fully blocked, because they need to open up that artery. So let's see if it is a non-ST elevated MI patient. Your first treatment is still aspirin. And then you determine that when and if they need a coronary angiogram. So we divide them into very high risk, and low risk. Very high risk is someone who has non-ST elevated MI, but they are hemodynamically unstable or they're in shock. They are having refractory chest pain. So even if you have given all the chest pain treatment, it's still having chest pain. Any of this will need an angiogram within 2 hours of diagnosis. And they will also have like dual antiplatelet therapy, like aspirin, clopidogrel. They will also have heparin. But this patient, because they are quite unstable, they will need, even if they are non-ST elevated MI, they will need the angiogram within 2 hours. What about high-risk group? High risk is that patient who has established non-ST elevated MI with elevated troponin. Patient was resuscitated. That means patient went into cardiac arrest. Or you can see that the ST is changing. So initially it was non-ST elevated MI, but now you can see that their ST is getting elevated. That patient will need a coronary angiogram within 24 hours. And for low risk who doesn't have any of this, they can have angiogram even sometimes as outpatient. But most of these patients will get an angiogram within few days. So basically, you need to know that for non-ST elevated MI, the treatment starts with aspirin. Then it is no longer that you need to call the catheter lab, you need to start planning for reperfusion. It's no longer like that. You need to find out whether this patient is very high risk or high risk. Very high risk, yes, they need an angiogram within 2 hours. High risk needs an angiogram within 24 hours. Okay? But they will be having all other treatment. They will be on monotherapy. They will take aspirin plus another antiplatelet. Okay? So aspirin, then clopidogrel, then low molecular weight heparin, and then angiogram based on their risk factor. So these are usually the treatment for non-ST elevated MI. And again, monotherapy is always there. So the only difference between the treatment of ST elevated MI and non-ST is the reperfusion plan. That means when it is significantly blocked, causing ST elevated MI, you need to call the catheter lab and do the reperfusion urgently. But for most of the non-ST elevated MI patient, they are not that much high risk. Most of the patient you will see that they are high risk or even low risk. That group of patient doesn't need an immediate attention. They can have their angiogram within 24 to 48 hours. Okay? Clear, everyone? All right. So let's say we treated a patient for MI. What could be the complications? This is from John Murtagh. So lots of patient after a MI treatment, they can have a left ventricular failure. Like they can start with pulmonary edema. So that's one complication. They can go into cardiogenic shock. They can have pericarditis, which is sometimes called Dressler's syndrome. And if they get pericarditis, they will get a sharp chest pain, like how pericarditis pain looks like. And you just need to put them on aspirin or any ibuprofen for the pain. So coming to another variation of chest pain called variant angina or Pringe metal angina. So Pringe metal angina is very uncommon, where patient gets severe chest pain, but the pathophysiology is that their coronary artery gets into a spasm. So they get vasospasm. Because of vasospasm, they get the pain because their coronary artery is not flowing as they should be. And during the vasospasm, there will be ST segment elevation on the ECG. Remember, as opposed to typical angina, Prince metal angina occurs during rest, mostly at night and early morning hours. And it comes as a cluster. So let's say you have got a patient who is coming to you saying that I get this intense chest pain at night. Okay? And then maybe during the daytime, they started to get the pain as well. And then you did an ECG, you found that there is ST elevation. You would be treating that patient as ST segment elevated MI because you are not sure. Then you did a angiogram. When you did the angiogram, there is nothing wrong. That is the time you can think that, well, it can be Pringe metal angina as well. In Pringe metal angina, the exercise test, routine coronary angiogram, everything will be normal. But what we can do this argonovin test. Argonovin can cause coronary artery spasm. So if you give the argonovin and patient starts to get the chest pain, that confirms the diagnosis. You can ask how to differentiate this with the Takotsubo by echocardiogram, because in echo, Takotsubo will have the ballooning, Prince metal will not have the ballooning. Treatment, because the problem is coronary artery spasm, you need to give something which can dilate the coronary artery, which is calcium channel blocker or nitrate. Okay? Not very important, just good to know. Next, we have got few other causes of chest pain. So aortic dissection is really important, and it comes in exam in different ways. Now, this is not just John Mottag, it's a combination of lots of research in together. Okay, so not directly from John Mottag. Aortic dissection comes with, as we know, that it comes with sudden onset severe retrosternal chest pain. And the pain is usually very severe. It has this tearing, ripping sensation, and it can goes to the back. Okay, so if we suspect something like that like it's very common presentation, like if a patient comes to us with a sudden onset severe tearing chest pain going to the back, we will think of aortic dissection. What will be our next step? Because this is chest pain, we do an ECG first. ECG will say nothing. Then we might do a chest X-ray even. You can do a troponin, you will do all those things, but troponin will be negative. If you do a chest X-ray, you might find that there is a widening of the mediastinum. Okay, but if you are suspecting aortic dissection, then you don't waste your time by doing all these unnecessary tests. You have to go directly after ECG. You go directly for a CT angiogram, because CT angiogram is quick test. It puts a dye and it goes to the aorta, and it can say that yes, this patient has got an angiogram. This patient has got an aortic dissection. But this is not confirmatory. If we want to confirm aortic dissection, the confirmatory test is transesophageal echocardiogram, TO. So the step-by-step would be ECG. If we are highly suspicious that yes, it is aortic dissection, you go straight to CT angiogram. And then if the question asks what is the most appropriate, what is the definitive investigation, that is TO. Now, we divide the aortic dissection into two parts. So we don't follow the DeBakey classification, we follow the Stanford classification. Stanford classification divides the dissection into type A and type B. Type A, you can see it's mainly, it starts, so type A has two types. So you can see that this one goes or starts from the proximal aorta and it goes throughout the aorta. Or this one just proximal. So when it is proximal, it's type A. And type B is if the dissection starts after the left subclavian artery. So this is the left subclavian artery. Distal to the left subclavian artery, the dissection, if it starts after that, it becomes type B. Okay? Do you guys understand? So you need to first know whether the dissection is a type A or type B, because the management is different. Type A will always need an emergency vascular surgeon doing a surgery, because this is high risk. So type A, the treatment is emergency operation. Type B, there are lots of patients who might not even need an operation. Type B, the main treatment is pharmacological, control their blood pressure. Okay, so for type B, because most of these patients are hypertensive, you need to control the blood pressure by, first we give IV beta blocker, which is IV ismolol or IV labetalol. If even after giving the IV beta blocker, blood pressure is still high, then you go for IV nitroprusside. So for type A, emergency surgery. For type B, you start with the antihypertensive, but IV antihypertensive. And which one first? IV beta blockers. Comes in exam a lot, okay? These are some link that I have put for Medscape. If you want to go through, you can go through them, but not really important. And lastly, we will finish with acute pericarditis. You remember we are talking about pericarditis like at first. Pericarditis, the pain is pleuritic chest pain, which means pain will be left-sided or retrosternal. The pain gets aggravated with coughing, deep inspiration, sometimes even brought on by swallowing. It is relieved by sitting forward, but worse with lying flat. And most of the time you will get that patient had a recent viral illness. Apart from virus, it could be connective tissue disorder, like SLE patient can have this. Could be uremia, someone who has got like severe kidney failure, they can get it. Even post-MI patient can get it. So what will you do? So on examination, you get a friction rub. If you do a ECG, that will give you most of the diagnosis. So ECG will show like widespread ST elevation in almost all leads. When we do your ECG class, you will know. So you get ST elevation everywhere. And then sometimes we do an echocardiogram. Why we do echo? Because pericarditis patients sometimes can develop pericardial effusion. Or sometimes it could be myocarditis and presenting as pericarditic chest pain. So to rule out myocarditis and also to check whether there is any fluid around the heart, we do the echocardiogram. What's the treatment? The main treatment of pericarditis is colchicine, and you give the colchicine for 3 months. Plus, you can add aspirin or ibuprofen. Okay? Now, this comes in exam. So very important to know that what is the treatment of pericarditis. So colchicine is the main treatment plus an NSAID. Okay? Few other chest pain which we discussed initially, like if it is a esophageal pain, like gastroesophageal reflux, we know that the pain will come in the middle, like a burning chest pain, right? And patient will say the pain gets worse when they bend over or when they lie flat. And they will say that especially at night time, because nighttime they usually have their dinner and then they lie down and all the food comes up. You know what is reflux, right? So that's how the esophageal pain will come. Costochondritis, so that was the other one. So you see this costochondral junction, this is the cartilage and the bone. So this costochondral junction sometimes can get inflamed. That is what we call costochondritis, or it has another name called Tige syndrome. So costochondritis, this causes mild to moderate anterior chest wall pain. So patient will have this sharp pain, and pain can get worse with breathing, or even a space, like sometimes even just changing the position. It can also be preceded by a virus. So how do you differentiate? Because it can be, you can think that it is pericarditis because the pain has this characteristic, right? Like left-sided pain, exaggerated by breathing, and had a upper respiratory tract infection. The only way to differentiate is that if you press on their costochondral junction, it will be tender. If it is tender, it is costochondritis. If it is non-tender, then you can think of pericarditis and others. Okay? And that's it. That's it for chest pain, guys. I hope you enjoyed the session. I know it was a roller coaster, but as you can see, even just discussing one chest pain can take a good amount of time. But I appreciate that most of you are here, so that's a good sign. So slides, the notes are for only course students. So course student already got the notes in the portal, but not for anybody else. And the treatment of Prince metal angina is you need to give them something which can open up the coronary artery, which means nitrates, calcium channel blocker. Oxygen will be given because it is a ischemia, right? So part of the heart is not getting blood supply. So you need to give the oxygen at least to supply that oxygen to that muscle. That's why we give oxygen, but it's only if it is less than 92%. The portal notes should be loading. You just need to wait for a few seconds. So usually if you give them 20 seconds, the notes will load without any problem because these are quite big. So some of them are like more than 100 pages. So it can take just few seconds to open, but keep that time. But even after, like if you're waiting for 20 seconds, it's not opening, then please send me an inbox because it should not be the case. Okay, if anyone having this problem, just send me an inbox in my messenger. We will have a look into your portal. Okay. Yes, you should read the notes because like it's up to you. How you do your preparation is all up to you. But yes, these slides are important. And it's very difficult to remember everything that I said. So yes, go into the notes, give it a read, understand everything. Even if you need to listen to this recording, do it. But yes, how you do it, it's up to you. But the good way is yes, read the note. And even sometimes initially you might need to listen to the recorded class again to get it all together. How many hours you need to study? It's people to people varies. If you are a slow learner, you need more time. If you are fast learner, you don't need a lot. But at least keep 6 hours a day for at least just to go through everything. Okay? This is already uploaded in your portal as a PDF. I'm sure. I'll check that, but I'm sure I have. No, you don't need to read all the chapters of John Murtagh, just the one that we are showing in the class. And notes are enough. When notes are not enough, then I will tell you that read this from John Murtagh. But most of the time, it is enough. Unstable angina management is the same like acute coronary syndrome. You will manage it as acute coronary syndrome. So it's all depend on, so most of the unstable angina patient will be taken to the hospital. They will get a troponin. If troponin negative for multiple times, they will be termed as unstable angina. For them, you just send them back home with all the other medication like aspirin, beta blocker, and all, but they would be having an angiogram later on. Yeah, like definitely this class is more than enough for cardiology. Not important, Dr. Ibrahim. If I don't discuss something, it is not important. Okay, so this is all about tonight. So we will have another session on cardiology, and we'll be finishing most of the other topics like heart failure, valvular heart disease, and all of palpitations and all. But again, we will not discuss ECG in that class. So ECG, there will be a class in the course. You will get the schedule when these 2 week sessions are over. Okay. You can't find therapeutic guidelines, you will need to buy the subscription. Okay. All right, everyone, that's it for tonight. Thanks, everyone. Take care. Have a good night.